And without further ado, I am very thrilled to introduce Dr. Claire Ashton-James as today's distinguished speaker. Dr. Claire Ashton-James is a social psychologist and associate professor of pain management at the University of Sydney Medical School. She draws on her expertise in social cognition, interpersonal behavior, and emotional regulation to elucidate the impact of a person's social context on their experience of pain and responsiveness to pain treatments. She's the founding chair and current secretary of the Social Aspects of Pain Special Interest Group at the International Association for the Study of Pain. She has a particular interest in the impact of patient-provider interactions on provider empathy, treatment decision-making, and communication on the one hand, and patient engagement with and responsiveness to treatment advice on the other. I just have to interject, Dr. Ashton-James has been an amazing collaborator and just so skilled with the Empower Opioid Tapering study, where she has advised us and the entire study team on how clinicians can best engage with patients around very difficult and sensitive topics. So she's just been amazing in that regard. She uses a combination of qualitative and quantitative research methods and consumer co-design. Her program of research and teaching activities contribute to a growing awareness of the critical role of social processes in patient outcomes and the need to identify and address social factors contributing to the assessment and treatment of both chronic and acute pain. In today's presentation, she will draw on 8 years of research investigating clinician perspectives on social aspects of pain to reveal individual, social, and structural barriers to addressing social contributors to pain in practice, describe evidence-based strategies for overcoming some of these hurdles, and illuminate a path towards increasing clinician engagement with social aspects in pain in practice. So Dr. Ashton-James, without further ado, the floor is yours. She will be speaking to us on the topic of addressing social aspects of pain in practice, challenges and opportunities.
Thanks so much, Beth, for that lengthy introduction. I will now go ahead and share my screen. And let's see. One sec. All right, if I could just get a thumbs up from Ashley that's all presenting as it should be.
Perfect. Yeah.
Great, thank you. All right, so thanks again, Professor Darnell, for inviting me to speak with you all about social aspects of pain and how we can make bold steps towards addressing patient social context in clinical pain care. I'll make the point today that social contributors to pain are relatively neglected in pain management. And I suppose the primary goal of my talk is really to inspire you to join a growing league of researchers and clinicians who are working towards optimizing pain management outcomes by taking a more thorough social history and by targeting social outcomes in their treatment formulations. So by way of background, for nearly a century, a person's social context has been recognized as a key determinant of variability in pain experiences. In 1836, Dupuytren's reported to have observed a stark difference between the pain experienced by civilians and military personnel in response to roughly equivalent injuries. He says, what a difference there is in the morale of those we treat in civic hospitals and those hit by murderous fire on the field of battle. Later on in 1956, Beecher then conducted a case control study, providing further evidence supporting the powerful effects of the context of a person's injury on their experience of pain. Beecher found that only 35% of military personnel required analgesia for traumatic injuries resulting from combat, relative to the vast majority of civilians with similar injuries sustained by accident. Beecher concluded that the intensity of suffering is largely determined by what the pain means to the patient, and what the pain means to the patient depends on the context of their injury. And now there is a substantial body of interdisciplinary evidence for the role of individuals' social context in their understanding of pain, pain perception, pain expression, and pain prognosis. Yet, the social determinants of pain are relatively rarely considered in the context of acute and chronic pain prevention and management. In their 2007 review, Pain in Pain, Blythe and colleagues reflected on the potential for social interventions to improve pain management outcomes and to reduce the incidence of chronic pain, noting that very few biopsychosocial interventions seem to have addressed the social component of pain. That was in 2007. Now, since 2007, systematic reviews of purportedly biopsychosocial pain treatments have consistently failed to surface social interventions or treatments targeting the social context of patients. Instead, pain assessment research, education, and care have been overwhelmingly directed towards intrapersonal, biological, and psychological determinants and consequences of pain. It may be that before researchers and clinicians are motivated to pay closer attention to and address social contributors to pain, the following key questions may need to be answered. Why is it necessary to consider social contributors to pain in practice? What is the scope of social contributors to pain and pain management outcomes? How does social context get under the skin to affect pain experience and expression? What are the social outcomes of multidisciplinary approaches to pain management or current approaches to pain management? And what are the barriers to addressing social context of pain in practice? And finally, what can clinicians do to address social vulnerabilities to pain in practice? The aim of this presentation, again, is to facilitate interest in and a self-efficacy for addressing social aspects of pain by addressing each of these questions in turn. First of all, the why. There are several whys, and the first is that if the cause of pain is social, then so must be the treatment. Psychological and physical treatments can only go so far in the treatment of pain that is really a response to social adversity. For example, imagine that a child is being bullied at school. She becomes socially isolated from her peers, and over time starts to show social skills deficits, I should say. As she becomes more estranged from her peers, the chronic stress of her social isolation and exclusion causes physical symptoms of gastrointestinal inflammation and pain. When she attends a multidisciplinary pain clinic, she is offered mindfulness-based approaches to manage stress and is offered a nutritional program and medications to reduce inflammation and pain in her guts. But she is not provided with support for developing healthy and supportive peer relationships. It is plain that exposure to the stress of social exclusion will continue as long as her interpersonal skills and peer relationships are not a focus of her care. Mindfulness may be effective in managing interpersonal stress, but surely the most effective treatment for her would be to address the cause of the stress. A second reason why it's necessary to address social contributors to pain in practice. Social pains affect treatment gains. Patients who have higher satisfaction with social roles and relationships have better treatment outcomes. Oh, sorry, I'll go back one slide, which I skipped over. So consistent with this, a prospective longitudinal study led by Professor Sean Mackey at Stanford found that in patients attending a multidisciplinary pain clinic, social isolation was associated with worsening pain interference over the course of their care. Interestingly, cross-lagged longitudinal analyses revealed that perceived social isolation was associated with later pain interference, but not vice versa. These findings suggest that the restoration of social roles, relationships, and increased social integration may be really critical to the achievement of maintenance of therapeutic gains. What I particularly like about this study is that it was conducted in the context of clinical pain care. These are not people in the community who are not receiving any care for their pain, and yet their pain is worsening despite care, despite access to multimodal care, in fact, because of social isolation factors that are impeding their care. In addition, social outcomes are patient-centered outcomes. Disruption of social relationships and participation in social roles may be more important to patient quality of life than physical functioning. In a survey of 800 patients with chronic pain, 2/3 rated social outcomes as extremely important, and social activities were among the most commonly valued treatment outcomes. These studies and these results also converge with research, yet again, led by Professor Sean Mackey at Stanford, which found that the disruption to social relationships actually mediated the relationship between impaired physical functioning and emotional distress, indicating that satisfaction with social roles and relationships may be a more salient predictor of emotional well-being in people with chronic pain than physical functioning. Now, these further highlight the particular importance of social factors to pain-related distress and the importance of targeting social functioning when formulating treatment approaches for chronic pain. And finally, it is necessary to address social contributors in pain practice because COVID-19 has undoubtedly exacerbated social inequalities, undoubtedly exacerbated social vulnerabilities in pain, including social vulnerabilities like social inequality, lack of access to care, and also loneliness. People living with chronic pain who may have entered the pandemic with fewer social resources than others may have become even more vulnerable as a result of the pandemic. In addition, extended periods of lockdown and social distancing measures and changes in the physical connectedness of society that has persisted since the pandemic have contributed to the rise of loneliness. Social networks have become smaller and weaker. We simply cannot take it for granted, if we ever could, that patients have social support networks in place to facilitate their recovery outside the consultation office or outside the pain management program. Okay, so let's agree that social aspects of pain care are important, nay, necessary to address in pain care, perhaps now more than any other time in history. It is important to realise that the scope of social aspects of pain goes far beyond social roles and satisfaction with relationships. A multi-level model of social contributors to pain and the role of social contributors within a larger system of processes shaping the pain experience was laid out by George Engel in 1980. 1980 was over 40 years ago. In Engel's model, social systems shaping the individual's experience of pain include nationalities and other social identities, cultures and subcultures, communities, families, and interpersonal relationships. These systems, in turn, were said to shape the subjective experience of pain through their interaction with people's cognition, affect, behaviour, their nervous system or physiology, their organ systems, tissues, cells, organelles, and molecules. Since 1980, there have been several updates in addition to Engel's model. Most recently, I've worked with a consortium of interdisciplinary pain scientists from IASP's Social Aspects of Pain Special Interest Group to further explicate interactions between the multi-level social determinants and consequences of acute and chronic pain across the lifespan, and with an emphasis on intersectionality. I realise that you can't see the details of this model properly in this slide, but we're very proud of it, and I think it looks beautiful, so I put it up here to show you anyway. Our model describes social processes, positions, systems, and institutions that contribute to pain at 3 levels of analysis: interpersonal, group, and societal. You can see here that interpersonal processes include, and positions include, social isolation and loneliness, stigma and solicitousness, amongst many others. I think perhaps interpersonal processes contributing to pain are probably the most well-known among pain researchers and clinicians. And look, recently there's been some fabulous work looking at some fabulous prospective longitudinal analyses of the relationship between loneliness and pain. Loeffler and Steptoe published a paper in, I think, 2021 in Pain, showing a bidirectional relationship with loneliness and the development of chronic pain over time using a UK-based longitudinal study database. Others have replicated these findings, and in fact, the relationship between loneliness and pain 5 years later was originally demonstrated in 2014. Perhaps it's more important now, not more important now, but I think it's more visible in our attention, more the focus of our attention given COVID and the impact of loneliness on everyone in society, regardless of their social status. So it's become a focus of research. Whitney Scott at King's College London has conducted similar studies looking at people's experiences of stigma and their experiences of acute and chronic pain 5 to 10 years later, also using these UK-based databanks. And Toby Newton-John and Anne-Marie Cano and Amanda Williams have conducted an enormous amount of research looking at partner behaviour and solicitousness and how that influences the experience and expression of pain and recovery from pain, responsiveness to treatment. Group processes and positions, there's several here. I won't read them all out, but I just want to highlight like a few of these group processes and positions. Group status is an interesting and problematic, I think, contributor to pain in that there's often group status differences between clinicians and patients, which can interfere with the process of developing trust. It can interfere with communication. It can interfere with effective empathy and emotion perception from clinicians to patients. And it can really disrupt normal, implicit, automatic behavioral processes that usually facilitate rapport building between individuals. And Stephen Anderson, Adam Hirsch and I wrote a paper recently on this issue that was published in Pain, where we highlighted the problems that the confounding role of experimenter and participant race disparities, differences in the racial identity of experimenters and participants in pain research. And we argue that it's possible that that differences in the racial identities of participants and experimenters in pain research may be contributing to racial disparities in pain or racial differences in pain sensitivity that we often see in experimental research. Somewhat of a controversial paper, very welcome to ask me about it later. But certainly brings up a lot of issues about group status and how that works in clinical care. Group cohesion is fascinating, and there's some really beautiful studies not conducted in the field of pain, but in evolutionary social psychology, looking at participation in choirs, rowing teams as well, and looking at group synchrony and behavioral synchrony and this experience of cohesion and how that influences neurophysiology, how it influences mood and consequently pain sensitivity. So that's really interesting research that it might inform how we direct people to activities in our care. And neighbourhood trust is also a really fascinating and a quite sad, I suppose, fact of life that some people live in neighbourhoods that are unsafe, and the lack of safety and security in their home life or where they live and spend all of their time, most of their time at least, that chronic lack of safety, that chronic perception of threat leading to increased cortisol levels, inflammatory markers, and chronic pain. Societal systems. This is probably the least researched area and probably the most fascinating. Certainly legal systems I'll just give you an example. In Australia, we have different legal systems in different states, and the different legal systems are associated with different outcomes of injury. And so if people are allowed to sue someone who is the cause of an accident, they are 10 times more likely to develop chronic pain. Whereas if you're not allowed to sue, you see much lower levels of chronic pain reported. And I know there's obviously some issues with that data, but it's certainly worth attention. Compensation systems, differences in compensation systems is a really big factor as well. And a PhD student and I are working in this area to look at ways that we can change compensation systems and their interactions with claimants so that it can cause claimants less distress and reduce their likelihood of developing chronic pain following injury. I have never seen research into political systems and the incidence or prevalence of chronic pain or the impact of chronic pain. But I wouldn't mind sort of hypothesizing that there might be differences in dictatorships and democracies, but certainly that research would be difficult to conduct. So sometimes it may be the case that clinicians and researchers neglect social aspects of pain in their research and practice because perhaps they're not thinking about the ways in which these social context gets under the skin. And certainly this has been explicated in a huge body of research, which I won't review now. But there are cognitive, emotional, behavioral, and physiological mediators of the impact of social context on people's experience of pain. Kai Karos at Maastricht University does some fabulous work looking at the signal value of people who are sitting with us while we experience pain, the signal value of social partners, and if social partners are perceived as a threat, then noxious stimuli are perceived as more threatening, and they're perceived as more painful, they're experienced as more painful. Although when people in our immediate environment are seen as a threat, it can result in people showing less behavioral expression of pain, a suppression of pain expression, which actually is associated with an increase in physiological arousal, physiological markers of stress, and increased pain reports. So that's really fascinating work as well. Perceived injustice and the experience of anger it's well known to be associated with worse pain and worse pain prognosis. And some nice research, just to go back to the loneliness research that Loeffler and Steptoe conducted. They actually looked at the mediating role of inflammatory cytokines, C-reactive proteins, and interleukin, or these inflammatory markers. And they found that have the presence of inflammatory markers together with loneliness was predictive of the experience of pain at a later date, whereas those people who experienced loneliness without the inflammatory markers were less likely to develop pain later on. And of course, we should just mention that each of these mediators interact with each other, reinforcing and maintaining their effects on pain experience. So given the clear importance of addressing social outcomes in the treatment of pain, it follows that social outcomes should be prioritised, I feel, in the evaluation and measurement of pain management and the evaluation of treatment effectiveness. However, when the Initiative on Methods, Measurement and Pain Assessment, the IMPACT Consortium in clinical trials, recommended core outcome measures for chronic pain management, interpersonal relationship functioning measures were not included among them. Perhaps as a result, a recent systematic review of 70 studies of multimodal pain therapy found that the most commonly reported outcomes of pain pain management treatment, multimodal pain treatment, were pain intensity, depressive symptoms, and physical functioning, with satisfaction with social roles and relationships reported in less than 10% of studies. And I should note that in those 10% of studies are several studies conducted at Stanford where social outcome measures are routinely taken. But it is an outlier. And so if I'm talking to everyone from just Stanford here, then you're probably thinking we're already doing this, but it really is an outlier in terms of what's happening across the United States, across Europe, and across Australia, and across the world. So just to stop for a moment, it is really certainly possible, possibly likely actually, that if we were to measure the social outcomes of our multidisciplinary pain programs as they currently exist, where social interventions don't play a major role in treatment formulations, it's possible that many of our programs would be associated with positive improvements in social functioning or satisfaction with social roles. Indeed, cognitive behaviour therapy for pain very often includes interpersonal skills training as part of the behaviour change strategy. And furthermore, CBT programs for pain are often conducted in groups, which may indirectly improve patients' feeling of belonging and social connectedness. I was recently involved with a study investigating the role of the group itself, and particularly the processes occurring within the group in the prediction of individual pain management group pain management program outcomes. The objective of the study was to explore whether social group processes were relevant to key treatment outcomes, including pain self-efficacy and depression. We measured patients' sense of belonging and group identification at the beginning of the group pain management program that was in Sydney at the Royal North Shore Hospital. And we measured sense of belonging and group identification weekly over the course of the program, which was actually delivered 5 days a week for 3 weeks. So it's a very intensive inpatient program. Changes in pain, self-efficacy, depression, and disability were measured from baseline to follow-up. No other social outcome measures were taken because they were not, and are still not to this day, included in routine pain management outcome surveys, assessments. Patients reported in this particular study, patients reported significant changes in their sense of belonging and group identification over the first week of the program. And these gains were maintained over the remaining 2 weeks of the program. In addition, we found a relationship between changes in group identification and changes in pain-related disability, and an association between changes in sense of belonging and changes in pain self-efficacy. So it is certainly possible that treatments are not necessarily targeting social outcomes do incidentally have a positive impact on social outcomes. However, more evidence is certainly needed. And indeed, I should point out that the effect sizes reporting in our study here are very small. And it is very possible that the positive effects that we found of group CBT on sense of belonging and group identification were not maintained once patients ended the program and went back to their home lives, something that we don't know that would need to be followed up in future research. So I do remain skeptical that multidisciplinary pain care that doesn't include targeted social interventions can improve social outcomes. I remain skeptical on that point. However, I acknowledge that it is certainly possible, and there would be large variation between pain programs. So that's, depending on the quality, I suppose, of the pain program and the quality of the CBT that's offered. Okay, so why aren't social outcomes routinely measured in pain management everywhere in the world except, through Quire and the Quire system? I have worked with there's an electronic persistent pain outcomes consortium or collaboration, the EPOC collaboration in Australia, which is it's a standard set of outcome measures that all pain clinics that receive any funding from the government have to use and in their routine care. So patients need to fill out this particular battery of assessment tools before and after treatment, as well as 3 months after and at follow-up. And this EPOC collaboration included, it was an interdisciplinary collaboration that developed the measures, and there are no social outcome measures in EPOC. I recently spoke with the EPOC management to ask them, would it be possible to include some social outcome measures in EPOC? And the response was, well, we just don't know what social outcome measures are, and we're not really sure that they're brief, and we don't really know whether or not social outcome measures are validated in patients with chronic pain. And so I took that as a challenge and worked closely with Stephen Anderson and Sean Mackey and Beth Darnell from Stanford to develop to collate, I should say, measures of social outcomes that have been validated in populations with chronic pain. And you can find this library of measures in this particular publication here on this slide. Now, these measures are really brief. We chose measures that are brief and that are validated in people with chronic pain. And what's important about these measures is that they can be used not only to measure outcomes, but also at baseline or in an initial consultation to identify patients who have greater social vulnerabilities, who are most likely perhaps to benefit from some social interventions. So if that you use a stratified care system, these measures could be used to stratify patients based on risk. So just to summarize so far, the scope of social contributors to pain are multi-level. If we neglect to address social contributors to pain in practice, we risk failing to achieve or maintain our treatment outcomes. The scope of social contributors to pain are multi-level, intersectional, and shaped by life stage and life history. Social context gets under the skin by influencing cognition, emotion, physiology, and behavior. And it is possible that multidisciplinary pain practice improves social outcomes to some extent, but social outcome measures are not routinely taken. So it is also possible that targeted social interventions are actually needed. What are the barriers to addressing social contexts of pain in practice? To better understand the barriers to addressing social aspects of pain in practice from the perspective of clinicians, my team and I conducted a descriptive thematic analysis of 133 clinicians' open text responses to the question, in your experience, what are some of the barriers to communicating with patients about social factors that may be contributing to their pain? Clinicians in this sample were physicians, psychologists, physiotherapists, nurses, and other healthcare providers who were enrolled in a postgraduate pain master's program at the University of Sydney. We collected discussion posts over a 5-year period from 2007 to 2022, so these are recent perspectives. We identified 3 main themes and 2 sub-themes. The first theme I'll discuss with you is it's not us, it's the patients. The second, well, we would if we could, but we can't, with sub-themes, the system is really not equipped for this, and we are not equipped for this. And the third theme, where there is a will, there is a way, where many of the clinicians in this sample did identify strategies that they might use in the future to be able to discuss social aspects of pain with their patients more freely. So the first theme, it's not us, it's the patients. Now, this theme is really clinicians' perspectives on why they don't feel free to discuss social aspects of pain with patients. And the perspective in this theme is that they would, but patients wouldn't like it. So it's an expectation of how patients would respond to them asking about their social context. And I really did find this fascinating because I don't know of any empirical research showing that patients would respond negatively to being asked about their social context. And in fact, in my experience as a communication coach and doing communication research, inquiring about someone's social context should theoretically make that person feel like the clinician is trying to get to know them or understand them better. And so it's really interesting that a large proportion of the clinicians across the 5 years said, look, we can't do that because patients would really respond very negatively to that. There were also, the presence of others in the room is obviously a real limitation, lack of confidentiality. Interestingly, when explaining their perspective that that patients wouldn't like it. A lot of the clinicians referred to culture, patients' culture, and social identities. And so there was really absolutely stereotyping involved in this expectation of how people would respond based on the culture they come from, based on their ethnic background. There was a strong sense that patients may become distressed, and that was seen as a barrier to asking these questions. Strong beliefs that patients have biomedical beliefs about pain, and therefore we really can't ask about anything but their biomedical sources of pain. Patients will feel stigmatized. That's fair enough, I think, to be concerned about that, absolutely. But there are ways around that. And concerns that patients will think it's out of their scope of practice. So worrying that patients might not expect them to be asking these questions, and therefore it might feel out of practice. And certainly that was a concern that was expressed mostly by physiotherapists, actually. The second theme was we would if we could, but we often can't for various reasons. The first being we're not equipped for this, and the second being the system not being set up for this. With regards to clinicians feeling that they are not equipped for this, there was issues of education and resourcing, many reflecting that they had a lack of knowledge about social contributors of pain, social contributors to pain, that this is not something that they were taught in their physiotherapy, medical, or even psychology, clinical psych programs, that this was news to them, that they'd only just learned it. So how could they possibly have started doing this in practice until now? That they'd had a lack of training in how to take a social history and how to elicit social concerns or identify social vulnerabilities. That's a real barrier, absolutely. Discomfort with patient disclosure of social adversity. So, and here it was clinicians feeling not equipped in their training to be able to cope with what they hear when they inquire as to the social challenges and social vulnerabilities. There was a sense that clinicians felt concerned or worried that if they were to hear what people were going through, they wouldn't know what to say or what to do, or how to refer them, or not know how to respond to this adversity. It's relatedly having limited resources and skills to address social risk factors. In terms of the system, interestingly, clinicians mentioned that there's a real biomedical focus of treatment guidelines and protocols, and so they felt that if they were to take a social history, they would be acting outside of treatment protocols, and that was particularly in acute pain settings. Interestingly, the absence of social outcome measures was a barrier to engaging in discussion about social aspects of pain, and certainly a barrier to finding ways to improve social outcomes, because it's not a KPI. It's not something they're going to be rewarded for. There's no carrot at the end of that. Perhaps that's a very cynical view, but this is the view that was expressed by these clinicians, that no one's measuring whether or not they have positive social outcomes in their treatment, so it's just not a priority. And certainly in Australia, the government does reward pain clinics with further funding for having more positive outcomes, and so there may be some conflicts of interest in putting social outcome measures into routine measurement if people are worried that they might not be able to show improvements in social outcomes, and that might affect their funding. So, of course, this is a systemic problem. Lack of privacy or lack of time in the clinical environment, certainly an issue in acute pain rounds, and demands of working within the compensation system, where the notes that you take can impact on whether insurers are willing to pay for treatment, willing to believe in a person's disability. So that's a really real problem that's worth considering. The third theme is that where there's a will, there's a way, and clinicians reflected on, the need for greater patient education, clinician education, to cultivate curiosity and establish trust. And let me just briefly touch on patient education and these other two for a moment. Patient education is, it wasn't that long ago that educating patients on psychological contributors to pain was seen as quite controversial and scary. And in fact, to this day, we still see several scoping reviews and qualitative studies looking at barriers to psychobiological care. They say psychosocial, but if you read the papers, it's really just psychobiological care in musculoskeletal pain, looking at physiotherapists, the barriers to physiotherapists using psychologically informed care. So we're still talking about whether or not physiotherapists can take a psychologically informed approach to physiotherapy and musculoskeletal care. It was an issue, it still is an issue, but I'd like to think that we can now also talk about socially informed care. It's often referred to as trauma-informed care, which is related, certainly, so social vulnerabilities. But I think we can broaden it beyond trauma to social vulnerabilities more broadly. So patient education, we've done this before, and we can do it again. Cultivating curiosity is important. If we are curious about the context of the patient, if we focus on the patient, not the pain, then we're going to be more curious about their social context, and these questions about social context will be easier. And it may be important to establish trust first and foremost, that it is possible that patients might respond quite negatively to probing about their social context, especially if they don't expect these questions or these probes. However, if we first establish trust, then we're more likely to be able to encourage disclosure of social vulnerabilities. In order to address social vulnerabilities in practice, I sort of have outlined a 4-step process here. 4 steps seems too long. I really do think it seems too long, but there are, I guess they start from within the clinician and work up to actually taking steps and implementing social interventions. And I think that the reason that I've highlighted step 1 and 2 and 3 is because these are things that we can do right now without any resources. These are things that are in our control. They don't depend on our systems or our environments. They really depend on us. So step 1 is just honest self-reflection and humility and responsiveness to clinician barriers to addressing social vulnerabilities in pain practice. I think it's important that clinicians acknowledge that their own implicit biases play an important role in health inequalities. That we have biases and stereotypes about patients that affect the questions we're willing to ask. Often clinicians in the qualitative research that I've conducted have said that they realize that they do take a social history, but they take it without asking the patient. They just take it based on the patient's skin color, level of education, living situation, postcode, number of children. And so they'll find out a bit about the patient, and they will use those cues to take an implicit social history, which I think is unfair, right? And we really need to, again, develop this and cultivate humility in social history taking and recognize our own biases and shortcuts that we're taking. I've talked about this elsewhere in other forums, that I really do believe we can use, if clinicians can develop a habit of checking into their emotional responses to patients, they can identify when it's important to reflect on their biases. So if you have a negative emotional response to patients, perhaps it's underpinned by perceptions of low warmth, low competence, or some stereotypes that need to be addressed. And recognize that these are barriers to engaging in conversations about social vulnerability. So it starts with the clinician. And then we take a social history. Now, there are many ways you can take a social history, and just as there are many ways you can take a psychological or medical history. But I'd like to point out some of the therapeutic benefits of taking a social history in and of itself, regardless of what it is that you ask. Taking a social history signals that you're curious and interested in the patient's lives. It encourages further disclosure about their lives because you've already signaled and modeled interest in talking about these issues. It gently signals the relevance of patient social context to their experience of pain without sort of shoving it down their throat that there is an impact of their social context on their experience. We can gently signal the relevance of their home life by talking about it in relation to their experience of pain. It helps to develop trust and rapport. Patients are more likely to note that, their clinician gets them. They get me, if they've had an opportunity to tell their story. And importantly, discussing social vulnerabilities elicits empathic opportunities. It gives us opportunities to build trust, opportunities to respond to hardship. If we don't know the hardships that people have gone through, we don't have the opportunity to express empathy, and we don't have the opportunity to develop trust and show our trustworthiness. As I mentioned, there are many ways of taking a social history, and these are some examples of different things that I would recommend reviewing. And it's possible that clinicians are already reviewing many, if not most, of these things when they take their history already. I suppose I would emphasize the importance of taking a social history as opposed to just a history, because then you're less likely to miss out on different things, and it also is more likely to direct care. So acknowledging social vulnerabilities is something that we can do once we've taken the social history. And this is a way of actually addressing social vulnerabilities in a very soft way. And that is because the acknowledgement of a patient's social circumstances draws their attention to social concerns that may require action. And so I like to think of this as planting seeds. So we don't need to necessarily address domestic violence in a particular consultation on a particular day, but drawing someone's attention to the fact that that might be something that needs to be thought through and addressed plants a seed that then patients can go and think about after their consultation and in subsequent consultations. Validation of social challenges gives patients permission to address rather than deny their challenges. Many are very stoic and don't want to whinge about their problems other than pain, but as long as we're denying or suppressing these challenges, we're not addressing them. And so validating the social challenges that people experience gives people then permission to address them, to acknowledge them and address them. And that's really important. It provides patients with insight into the context of their pain experience, and it might help to explain why someone with exactly the same injury in the same car accident has had a very different trajectory. And that's often part of the distress associated with sort of persistent pain, is that why me, the person next to me didn't have this happen to them. It encourages self-compassion, which is related, and self-compassion is associated with better outcomes in chronic pain. So finally, we can, I guess that the ideal scenario would be that we address the social vulnerabilities that we uncover and that we address them directly. And we can do that in very small ways that are very powerful, like just ensuring that there's an interpreter or a support person in consultations, by involving partners and family in pain education and treatment, by tailoring approaches and goals to the social context of patients. These are all socially targeted interventions, but they're very light touch. They're very simple to do, and many of us are already doing these things. We can encourage patients to set social goals rather than just physical goals. So, social goals, for example, would be strengthening relationships, reaching out to family, reconnecting with children, things like that. We can, a more deliberate and intervention would be to refer to specialist psychological or social services where appropriate, in the case of, for example, childhood trauma, or homelessness. We can utilize or develop peer support programs, and research that I'm involved in Australia. We have developed peer support programs for people from culturally and linguistically diverse groups, where we pair pain management program patients from Saudi Arabia and Pakistan and Vietnam, for example, with peer supporters who are from the same culture and the same gender. And we find that when we pair them up with someone from a similar background who speaks their language, they have much improved treatment outcomes. We can recommend digitally delivered support programs. Beth Darnell and her team have an amazing online program that they have developed that is accessible freely. My team in Australia, in collaboration with Beth Darnell's team, has developed SMS text messaging based social support programs. These are free, light touch programs that can just help people to feel connected. And, you know, a more arduous task, but arguably worth doing, would be to develop a library of free or low-cost community-based activities for people, and opportunities for them to be part of a group. So our final answers are that barriers to addressing social aspects of pain in practice include clinician concerns about adverse patient responses, clinician concerns that they lack the skills, knowledge, and resources to have these conversations, and systemic barriers, including biomedical protocols. There are, however, several ways in which clinicians can address social vulnerabilities to pain in practice. We can reflect on and respond to our own biases that might be impeding high-quality care or contributing to social inequalities in health outcomes. We can take a social history. We can get to know the patient behind the pain. We can acknowledge and validate social vulnerabilities that might be impacting patients' pain, and we can address social vulnerabilities directly by engaging patients with a variety of strategies for improving relationship quality and participation in social roles outside of their care. So to conclude, there are indeed barriers to addressing social aspects of pain in practice, but I believe that there are that we can overcome these barriers, and that it is important to do so. For, as Michael Marmot has said in The Health Gap and many of his keynote addresses, what good does it do to treat people and send them back to the conditions that made them sick? That ends my presentation for today, and I hope that you have some questions for me, or please get in touch.
Thank you so much, Dr. Ashton-James. Amazing topic and so much rich advice for us to consider. There are questions for you. So this is in the Q&A form, not in the chat section, but this is from Merit, who says, I don't know if you can see this, Claire, but I'm going to read it to you just in case you can't. For theme 1, it is not us, it is the patients. Can the things the clinicians do not ask because they cannot be solved with available facilities be added? Because recent year 1 and 2 months observership in PM&R, and what I saw is someone who complains about low back pain, and he was working as a carrier, tragically, I think, and in some countries where there is much more unemployment rates, there will be similar situation to that. So is there any aspect of pain with unsuitable profession and people, and since it is expected in countries where there is lower socioeconomic situation because of financial struggles?
So, so for the theme, it's not us, it's the patients. Can the things that clinicians do not ask, are there things that clinicians do not ask because they cannot be solved? Yeah, that is not a theme, like that's not something that came up, but absolutely, that's an excellent point. There are things that can seem unsolvable, and perhaps that's a barrier to clinicians asking about them or hearing about them, because then they might feel helpless. They might feel like they have to solve them, and they might feel unable to solve them. And I can imagine that might affect their professional self-efficacy. Absolutely. And I guess I would encourage that this might be actually a huge brick in the wall, actually, that clinicians are experiencing. I don't want to know about the domestic finance or the homelessness because there's nothing I can do about it anyway. But I guess I would encourage a different perspective, which is if you know about it, you can offer empathy and you can offer validation and you can offer acknowledgement and you can offer support. You can help the person with pain to see that their pain is experienced is part of a complex situation, that it's not their fault that they're experiencing chronic pain, that it is an understandable response to struggles and in life. And I think that will help to build some self-compassion and resilience. So I guess I would think about it just a bit differently.
Great, thank you. Dr. Bill Burrows, what approach might we take as providers to assess our implicit biases?
That's a great question. Look, so in the teaching that I do, I address implicit biases with clinicians, and I'm always overwhelmed, absolutely overwhelmed with capacity for deep honesty and humility when implicit biases are discussed in a group of clinicians who are all admitting to their human flaws. So it might be harder to self-reflect on your own because you might not give yourself permission to be human. But in the workshops and the teaching that I do, it's always in groups, and clinicians are always, they feed off each other. So one will start with, I had a homeless man and he just, the way he smelt made me recoil, and I couldn't even listen. I couldn't listen to what he was saying because I was overwhelmed by disgust. And then someone, it's not a sort of a negative, it sounds awful, but and then another person will say, that's really interesting. I personally don't have that response to that particular issue, but I do find that because of when I was brought up, I had a negative experience with this particular situation. When that type of person comes in, it makes me afraid. So people will highlight all the different ways and that they can experience bias, and it normalizes it. So I think that once you normalize it, people will allow themselves to reflect on it. And I also use the emotion cues as a sign of implicit biases, which is something I mentioned very briefly. So if people are finding that they don't have enough knowledge of stereotypes and things like that to be able to reflect on their own biases, I encourage people to instead just look for the emotional cues, and then we can extrapolate from that the perceptions that we have of people. Because, for example, perceptions of low warmth and low competence in certain people from certain social groups is associated with feelings of disgust and contempt, and we can feel those things.
I always said when I was working with patients in the clinic that pain is what would get people in the door, and then we would work on everything else once they were in the clinical office. And so much of it was working on relationships. So I know that this content and all of the wisdom and evidence-based strategies that you're bringing to bear are just so important, Dr. Ashton-James. I just want to really thank you for sharing all of your work, all of this wisdom, and a little bit of a toolkit with all of us that we can take that away and both think about it, think about where the field needs to go, and integrate it so that we can improve the care of all of our patients with pain. Thank you so much. Oh, one more question, if you're able to stay. I know you have a schedule, Dr. Ashton-James. This is from Anna Goya Ars. This was absolutely wonderful. In some cultures, social contexts, people may be more likely to trust recommendations, opinions from peers, and also use traditional remedies. Any recommendations on how to ask about this and address while being respectful of people's beliefs and cultures?
Yeah, that's really, really fascinating. And I don't know enough about different groups who might be more likely to trust peers than clinicians, but certainly that's what we get out in our peer mentoring programs. We call it the naturalistic helper. And we do find that in these particular demographics that we're working with who really are very quite socially disadvantaged in Sydney, from socially disadvantaged areas, there is definitely a mistrust. A lot of these patients are refugees, and there's a lot of mistrust. And so you can imagine, historically, this pain program in this particular area has sort of thrown up their hands and said, like, why are we even bothering to teach these pain self-management strategies? These patients are not interested, right? They're just not interested in this. And it turns out that they were just not trusting the advice coming from a privileged white clinician, and that they really needed to hear it from someone like themselves that they implicitly trusted. So basically what you're saying is reiterating the importance of that in particularly where there is a large power differential between the clinician tribe and the patient tribe.
Thank you. There is a question. Sheila Henderson asks whether you can, Ashley, if you can provide us with information about the CME certificates. You can either, Ashley's chatting it in. Okay, thank you for that. One last question here. The pandemic changes a lot of things, maybe loss of empathy for health. Do you have any strategies to focus on the patients again?
To focus on the patients again, I guess, look, it's going to be up to every individual clinician to change their focus to the social context of their patients, until we have systemic sort of changes in treatment protocols, but until we have guidelines recommending explicitly social interventions for pain, it's really going to take each individual clinician changing the way that they practice. I think that it'll happen in chronic pain first, and then I think that it'll happen in acute pain. I've already started advocating in the space of acute pain. Why are we not addressing the sort of social aspects of acute pain in hospitals? And so there are ways of doing it. So these things take time, but they don't have to take time for you. These are things that you can do tomorrow. You don't have to wait for the world to catch up.
Great. Well, with that, I think we are at time. Thank you again, Dr. Ashton-James. Thank all of you for joining this lecture, and we hope to see you next time.
Thanks, everyone.